Hey, my name is Reese Randolph, and I'll be doing my presentation on the foot. After this presentation, you will be able to identify and describe the bony anatomy of the foot, identify and correct common positioning errors that can affect diagnostic quality, locate key anatomical landmarks used in radiographic positioning, explain beam alignment and centering points, and collimation for each view. Okay, our first projection is the AP or AP axial foot. The SID will be 40 inches. The patient position, place the patient in a supine or seated position. Flex the knee of the affected side enough to rest the sole of the foot on the IR. The part position, position the IR under the foot. Center the IR to the base of the third metatarsal. The entire plantar surface rests on the IR. The CR, angle the tube 10 degrees toward the heel, entering the base of the third metatarsal, or perpendicular to the IR and entering the base of the third metatarsal. The collimation is 1 inch on all sides and 1 inch beyond the calcaneus and distal tip of the toes. Patient respiration is to hold still. Okay, so our labeled anatomy for our foot. So we have our phalanges, and then our metatarsals, and then our tarsals. So starting with our phalanges, we have our distal, middle, and proximal phalanx. And then for our metatarsals, we have our head, body, and base. Then we have our fifth tuberosity over here for our fifth. And then for our tarsals, we have our medial, intermediate, and lateral cuneiform, and then our cuboid, and then our navicular, and then our talus, and then our calcaneus. Then a little tidbit for why we do our axial versus our plain AP is that in our axial projection, it demonstrates the tarsal metatarsal joint space better and reduces foreshortening. Okay, so this is our AP axial high quality image with our eval. So we'll have proper collimation and markers. We'll have our anatomy from the top of the toes to the tarsals, and it may include the talus and the calcaneus. We have no rotation of the foot, demonstrated by equal amounts of space between the second and the fourth. So we have equal spacing between each. And then we have overlap of second through fifth metatarsal bases. So this is our overlap. And the axial projection results in improved demonstration of interphalange. And then metatarsal and tarsal and metatarsal joint spaces. So we have open joint spaces, and then open joint spaces between the medial and intermediate cuneiform. So right here we have open spaces, and then we want bony trabecular detail and surrounding soft tissue. AP axial poor quality image. So just by looking at this image, we can see that there is soft tissue clipped, especially on the sides between the first and the fifth. We see soft tissue clipped, and then at the distal toes, we can see maybe the second may be clipped. And then due to image quality, we just can't see if the joint spaces are open. And then it may be a little rotated medially by the space between the second and fifth metatarsal. There's a lot more space open between the second and the fifth. So it may be rotated up just a little bit. First question, the upper surface of the foot may be described as the plantar surface, anterior surface, or dorsum. And our answer is C, the anterior surface and the dorsum. Section is the AP oblique foot medial rotation. So again, the SID, 40 inches, patient position, place the patient in the supine or seated position, flex the knee of the affected side enough to firmly rest the plantar surface of the foot on the table. Part position, place the IR under the foot parallel with the long axis and center it to the midline of the foot at the level of the base of the third metatarsal. Rotate the patient's leg medially till the plantar surface of the foot forms an angle of 30 degrees to the plane of the IR. If the angle is more than 30, the lateral cuneiform tends to be thrown over the others. The CR perpendicular to the base of the third metatarsal. Collimation 1 inch on all sides and 1 inch beyond the calcaneus and distal tip of the toes. And hold still. Are labeled AP oblique foot. So at the very top up here we have our distal, middle, and proximal phalanx. And then we have our metatarsals. And then we're going to start with our intermediate and medial cuneiform. So we, on this very tip where the great toe is our medial, and then we have our intermediate right beside it, and then our lateral on the other side. Then we have our cuboid, our navicular, our talus, and our calcaneus. This little spot between the calcaneus and talus is our sinus tarsi. And then we're going to have our tibia and our fibula. And then another little tidbit is the oblique. Medial oblique is preferred over the lateral oblique because the plane through the metatarsal is more parallel to the IR, and it opens the lateral side joint of the midfoot and hindfoot. AP oblique high quality image. With our eval, we have proper collimation and marker, entire foot from toes to heel, proper rotation of foot. We can see proper rotation through the third through fifth metatarsal free of superimposition, base of the first and second metatarsal superimposed on the medial and intermediate cuneiform. So right here, our navicular lateral cuneiform and cuboid with less superposition than in the AP projection. So we can see that here. And then our tuberosity of the fifth metatarsal seen right here. Lateral tarsal metatarsal and intertarsal joints. We can see that. And then our sinus tarsi. Then our bony trabecular detail and surrounding soft tissue. For a quality image, we can see the foot is too oblique because the first metatarsal is overlapping the second and third metatarsal as seen here. And then the medial and intermediate cuneiform are overlapped right here, which those are supposed to be separated. So we need to oblique less. Next question is the lateral projection of the foot. The plantar surface should be perpendicular to the IR. Metatarsals are superimposed, or the talar fibular joint should be visualized. So our answer is 1 and 2 only. So the plantar surface should be perpendicular to the IR, and the metatarsals are superimposed. Projection is the lateral foot to the medial lateral. The SID is 40. Patient position. Have the patient lie on the table and turn toward the affected side till the leg and foot are lateral. Place the opposite side behind the affected leg. Part position, elevate the patient's knee enough to place the patella perpendicular to the horizontal plane. The medial surface of the foot should be parallel with the plane of the IR. Place the plantar surface of the forefoot perpendicular to the IR. Center the IR to the midfoot and align the IR's long axis parallel with the long axis of the foot. Dorsiflex the foot to form a 90-degree angle with the lower leg. The CR is going to be perpendicular to the base of the third metatarsal. Collimation, 1 inch on all sides of the shadow of the foot, including the medial malleolus. And the patient respiration is to hold still. Pathology that we can see with our lateral and oblique projection is the Jones fracture, which is a fracture of the base of the fifth metatarsal, as we can see here in the lateral and then here on the obliques. Lateral foot anatomy is, so we have our tib fib behind our fibula, and then we're going to have our talus at the top with our calcaneus, and then our navicular cuboid and cuneiform bones. We can see the base of them here, and then our base of the fifth that we talked about earlier in the Jones fracture, and then we have our heads superimposed at the bottom. Our tidbit for this one is the medial lateral projection is routinely used in most departments because it is the most comfortable position for the patient. Lateral foot high quality image. So we're going to have proper collimation and marker. We're going to have the entire foot and distal leg, superimposed plantar surface of the metatarsal heads, as we can see here. Fibula overlapping the posterior portion of the tibia, so we can see that right here. Their tibia taloid joint, and then bony trabecular detail and surrounding soft tissue. A poor quality image. Looking at this image first, we can tell that the foot is not flexed, as we can see by the toes and the fibula and tibia. We can assume that the soft tissue is clipped back here at the calcaneus and the tips of the toes. And then the metatarsal heads are not superimposed, which can be fixed by flexing the foot. The interspace between the first and second cuneiform are best demonstrated in which of the following? We have our lateral oblique foot, medial oblique foot, lateral foot, or our weight-bearing foot. And the answer is our lateral oblique foot.